Bugün Türk Göğüs Cerrahisi Derneği olarak çok önemli bir konuğumuz var. Hakikaten yıllardır özellikle akciğer kanserinin evrelemesinde büyük emekleri olmuş, liderlik yapmış bir misafirimiz var. Doktor Ramon Rami Porta kıymetli misafirimiz ve yine özellikle evrelemede uluslararası komisyonlarda ülkemizi yüz akıyla temsil eden kıymetli bir hocamız Ayten Kayı Cangır hocamızın moderatörlüğünde Doktor Ramon'u dinleyeceğiz. Bildiğiniz gibi 9. evreleme artık başladı akciğer kanserinde ve bazı değişiklikler, gelişmeler oldu. Doktor Rami Porta bu konuda bize detaylı bilgiler verecek. Öncelikle kendisine teşekkür ediyoruz bu davetimizi kabul ettiği için ve moderatörlüğü yapmak üzere mikrofonu Ayten Hocama takdim ediyorum. Buyurun Ayten Hocam.
Ee, Hocam, Senetli Hocam teşekkür ederim. Ben de bugün çok mutluyum. Herkese iyi akşamlar. Bu webinarımıza hepiniz öncelikle hoş geldiniz. Sizleri burada görmek büyük bir mutluluk. Bugünkü webinarımıza moderatörlük yapmak benim için de büyük bir onur. Bu fırsatı verdiği için Türk Göğüs Cerrahisi Derneği Başkanı ve Başkanı Sayın Atilla Eroğlu Hocama teşekkürlerimi sunarak başlamak istiyorum. Bugünkü konuşmacımız Ramon Rami Porta'yı tanıtmak benim için büyük bir onur. Kendisi dünyanın en saygın göğüs cerrahlarından biridir. Birçoğunuz onu zaten tanıyorsunuz. Ancak önemli katkılarını özellikle kısaca vurgulamak istiyorum. Doktor Rami Porta sadece olağanüstü bir göğüs cerrahı değil, aynı zamanda günlük pratiğimizi yönlendiren akciğer kanseri evreleme sisteminin en önemli mimarlarından biridir. TNM sınıflamasını geliştirme ve ileriye taşıma konusunda özverisi, dünya çapındaki akciğer kanseri teşhisi etme, tedavi etme ve anlama şeklimizi büyük ölçüde şekillendirmiştir. Bu alandaki liderliği ve kapsamlı araştırmaları, cerrahi stratejileri ve genel hasta bakımını derinden etkilemiştir. Kendisine tekrar teşekkür ederiz bu konuda. Ayrıca profesyonel başarıların ötesinde Doktor Rami Porta bilgisini cömertçe paylaşması, eğitime olan tutkusu ve hastalar için daha iyi sonuçlar elde etmeye yönelik sarsılmaz bağlılığı ile de tanınmaktadır. Birçoğumuz için ilham verici bir mentor, güvenilir bir meslektaş ve torsik onkolojinin sürekli değişen dünyasında değerli bir bilim kaynağı olmuştur. Bugün kendisinin akciğer kanserinde 9. TNM evrelemesindeki gelişmeler ve klinik sonuçlar konusundaki görüşlerini dinleme ayrıcalığına sahibiz. Doktor Rami Porta bizimle olduğunuz için teşekkür ederiz. Dear Ramon, we really appreciate your time and the floor is yours.
Thank you very much, Dr. Jangir and Eroglu, for your kind invitation to participate in this webinar of the Turkish Thoracic Surgery Society. It's always a pleasure to share with you some comments on the TNM classification that, as you said, is one of my preferred topics. In this occasion, the clinical implications of advances of the ninth edition TNM classification of lung cancer. However, before I start, I will also like to send my sincere sympathies for the big fire that you had in the north west of Turkey. This is a national disaster. We also had very recently national disasters in Spain, so I really feel very sorry for what happened in that beautiful hotel. So, okay, but now let's talk about the TNM. I have no conflicts to declare, and the content of my presentation will consist of a brief introduction. Then I will mention very briefly the innovations of the ninth edition to go directly to the practical implications, then a summary and conclusions. So just as a reminder, you can see on your left hand this pie. The blue color are patients from Asia and Australia. So nearly 60% of the patients of the 9th edition ISLC database come from Asia. About a quarter of them from Europe, then almost 20% from North America, and very few from South and Central America, Africa, and the Middle East. Turkey has participated with 6% of cases, and you have participated registering cases in the electronic data capture system, which is the best way to register cases. Cases registered in the EDC have almost complete data, and they are very useful for the analysis of the different descriptors and categories of the TNM. In general, China is number one in the EDC section of the database, and Japan is number one as batch databases. Batch databases means that there are institutions that they have their own database, and if they have the minimum number of elements that we can use to revise the TNM classification, we can use them as they send them to us. So I hope that you will keep participating in the 10th edition because it will be really interesting. Just to mention the valuable cases that we have for the 9th edition, we have more than 87,000. The number of lung cancer cases is very similar in the 8th and the 7th edition. The novelty in the 9th edition is that we have molecular data. Nearly 10,000 patients have some sort of molecular data that is being analyzed now. We haven't published anything yet, but we will try to see how molecular data influence prognosis beyond the prognosis given by the TNM classification. We will probably see a very simple and humble publication in a few months to see what we can do with the data that we have for the 9th edition, because the results of this analysis will help us proceed in the 10th edition, where we will have many more data about molecular characteristics and molecular profile of the tumors. So the innovations, this is the summary of the innovations. As you know, because I already lectured about this in Turkey, the T has no changes. The N has a subdivision of N2 into N2A, which means the involvement of a single mediastinal nodal station, and N2B, the involvement of several mediastinal nodal stations. N2, so they are ipsilateral or subcarinal. In the M, there is the subdivision of M1C into M1C1, which is multiple extrathoracic metastases in a single organ system, and M1C2, multiple extrathoracic metastases in several organ systems. These two changes here have implied changes in the stages, because now we have new TNMs. We have, for example, this T1 and 2A didn't exist in the previous edition. So now we have T1 and 2A that happens to have better survival than stage 3A, where T1 and 2 was in the 8th edition. So now it has a prognosis similar to stage 2B, and it has been moved from stage 3A to stage 2B. This tumor here, we already had it in the 8th edition. It's not new, but the prognosis is new. In the 9th edition TNM, prognosis of T1N1 is prognosis of a stage 2A, not a stage 2B. So this tumor has been downstaged from stage 2B to stage 2A. These two are new tumors. We didn't have them in the 8th edition, and T2N2B has been moved to stage 3B because it has worse prognosis than stage 3A. And T3N2A has been moved from stage 3B to stage 3A. This is very interesting because we already know that in the absence of metastasis, prognosis is led by the N component of the classification. And here we have a small t with a lot of lymph node involvement. It has worse prognosis than a bigger t, but a smaller nodal involvement has better prognosis here, stage 3B, stage 3A. So finally, there is a new pathologic descriptor, which is the cells spread through air spaces that will be included together with lymphovascular invasion and perineural invasion that were pathologic descriptors in the previous editions of the TNM classification. But there are other innovations. There are no changes indeed, but we have facilitated the list of descriptors of T2, T3, and T4. This invasion of the adjacent lobe already was a T2A descriptor, but it was not in the list, in the official list of T2 descriptors. It was in a table. In the UICC book, it was not in the manual. It was in the supplement published 1 or 2 years after the TNM manual. And in the AJCC book, it was in a separate table. These descriptors were defined by Clifton Mountain a few decades ago, and he decided what category they were, but they were never included in the official list of descriptors. Now, to avoid to go to the supplement or to go to this additional table, we have included them in the official list of descriptors. So this is not a new descriptor. It is a descriptor that wasn't here, and now it is here. The same with T3. Pericardium, we have avoided calling parietal pericardium or visceral pericardium because it was a little bit confusing. So it's only now pericardium. The phrenic nerve was already in this additional list. The azygos vein is new. It was not mentioned in the previous list of descriptors, but the azygos vein, which is in the mediastinum, but it is easily accessible and resectable, we thought it was better in the T3 category. And we have avoided the term Pancoast tumor because it is also confusing sometimes. And we have described the elements that must be invaded to classify this tumor as T3 or T4. So if the thoracic nerve roots are invaded or the stellate ganglion, it is T3. But if the subclavian vessels or the lamina or the spinal canal, cervical nerve roots or brachial plexus are invaded, then it is T4. We had in the 8th edition T3 Pancoast and T4 Pancoast. Now here we don't use the name, we use the elements that have to be invaded to classify it as T3 or T4. We have included the thymus here because it is a mediastinal organ that was never mentioned in the list, so we have included here. And we have also defined the great vessels. The great vessels were defined in the supplement or in this additional table. So it was complicated to go back and forth from one book to the other. So we have included them here as official descriptors of the T4 category. Great vessels that are the aorta, superior inferior vena cava, intrapericardial pulmonary arteries or veins, and the supraaortic arteries or brachiocephalic veins that were never described. So this is it for changes. Now let's go for practical implications of these changes. In the T component, as I mentioned, there are no changes. you see here that the survival curves of the clinical T categories and the pathological T categories separate very well. T2B and T3 get together here, but the survival is different and significantly different. And so we saw that the 8th edition categories worked well, so we didn't do any change. If it works well, why to change? So why to complicate more the classification? So now we already know the 8th edition T categories that are the same in the 9th edition. However, as tumor size matters a lot in the TNM, it is very important to measure the tumor size in the most precise way. Here you can see this mass here. It is impossible to tell the difference between the atelectatic component and the tumor component. But if we order a PET-CT, we see that the tumor, the neoplastic tumor, is here, and the T category has changed a lot. It's from T4 to T2A. So it's really important to use, at least in these cases where there is a telectatic lung that can be confused with the tumor, to have a PET-CT to better delineate the size of the tumor. Also, it is important to take advantage of the different projections that the new CT scanners provide us with. Here we have this endobronchial tumor in the axial projection. It has only 13 millimeters, but here in the coronal projection, it is 22 millimeters. So from T1B to T1C, the prognosis is different. Treatment may not be different, but prognosis is different. So we have to pay attention to the possibilities that we have to better measure the tumor size. And also, in this 9th edition, we have seen that the T component, parietal pleural chest wall, has a T3 prognosis when it is evaluated clinically. So the blue line here, which is chest wall parietal pleura, and the red one, which is other T3 descriptors, are the same. And they separate very well from the green line, which is T4. So T3 parietal pleura chest wall has a T3 prognosis at clinical staging, but you can see here at pathologic staging, T3 parietal pleural chest wall has a T4 prognosis. It is almost identical to the survival graph curve of the T4 category. So when there is a discrepancy between the clinical and pathologic stages or classification, the decision is not to change anything. So this is the reason why pathologic T3 parietal pleural chest wall was not upstaged to T4. However, I think that in clinical practice, this is a very good information, because if we operate on a patient with chest wall invasion and we can confirm it pathologically, we know that we have to classify the tumor as T3, but the prognosis is that of T4. So we can apply more intensive adjuvant therapy, or at least more frequent follow-up to see if there is recurrence or how the tumor evolves. So I think that even if this finding has not introduced any change in the classification, it has clinical relevance. Regarding the N component, the classic N categories, N0, N1, N2, and N3, work very well with the 9th edition database. You can see here at clinical staging, the 4 survival curves, very separate, and also at pathologic staging. But you will remember that in the 7th and in the 8th edition, we tried to quantify nodal disease by counting the number of involved nodal zones in the 7th edition and the number of nodal stations in the 8th edition. And the number of stations or zones involved mattered, but only at pathologic staging. We could not reproduce those findings at clinical staging. However, in the 9th edition, this simple way of quantifying nodal disease by the number of involved N2 nodal stations, N2A single N2 nodal station, N2B single multiple N2 nodal stations, have different prognosis, as you can see here. The green line is N2A, the yellow N2B, and the same at pathologic staging. So because this quantification of nodal disease could be validated in both clinical and pathologic classifications, we recommended the introduction of this subclassification of the N2 category for the 9th edition TNM. And it has been accepted both by the HACC and the UICC without any challenging. So this means that we have to be more precise than we were before in order to classify properly the involvement of mediastinal nodal disease. And in the absence of metastasis, we have very good recommendations on how to classify nodal disease. The American College of Chest Physicians recommends invasive staging when there is any type of suspicion of mediastinal nodal disease, either by CT, which means enlarged lymph nodes, or by abnormal PET scan, which means positive nodes on the PET scan. Sometimes there is high suspicion of N2 or N3, and when there is high suspicion, for example, when there is N1 disease or in central tumors, we also have to confirm to do the invasive staging of the mediastinum. Initially, with bronchial ultrasound, if you have it, EBUS or EUS, but if the results are negative, then confirmation with a more aggressive, if you want, more invasive procedure such as mediastinoscopy or video-assisted thoracoscopy is recommended because EBUS can have many false negative results. The European Society of Thoracic Surgeons has this algorithm that once we have applied CT or PET-CT, we can have two potential situations. When the mediastinal lymph nodes are positive, either by large or by a PET uptake, then if we have EBUS EUS, we have to indicate this technique. But if it is negative, we have to perform video-assisted mediastinoscopy because these large lymph nodes or positive lymph nodes have a high probability of being involved. So if they are negative, we can proceed to surgery. When the lymph nodes are negative, we have two different situations. In one situation, there is suspicion of N1, or the tumors are central or larger than 3 centimeters, or are adenocarcinomas with a high PET uptake. In these situations, EBUS EUS is indicated, or video-assisted mediastinoscopy, depending on the experience of the institution. And if it is negative here, we have to go to surgery. We can go to surgery. However, we have to be very precise in the EBUS EUS. We have to do it according to guidelines, to puncture as many nodes as possible and to do 3 passes of the needle in each lymph node. And if you know that in your institution, the negative predictive value of EBUS EUS is lower than that of your video-assisted mediastinoscopy, then you have to perform video-assisted mediastinoscopy to confirm negative results. In peripheral tumors with absolutely negative mediastinum and no suspicion of N1 disease, in peripheral tumors and smaller tumors, this invasive mediastinal staging can be spared and go directly to surgery. When we do EBUS TBNA, we have to have in mind several important findings. This is the experience of our own institution. We have very thorough bronchoscopists in our institution. They puncture all the lymph nodes they see, and they do all the required passes of the needle, and we have obtained these results. So it is clear that malignant lymph nodes are bigger than non-malignant lymph nodes. We already knew that. But in this large series of more than 500 resections with systematic nodal dissection and these 241 FAMLAs, there were 41 patients with positive lymph nodes. So more than 700 lymph nodes. This is a very meticulous study, and they were 119 malignant lymph nodes in 67 nodal stations. But you see here that the largest lymph node in all these stations was positive in 58% of the stations, not in all of them. Then we also found that the largest lymph node was negative, and the second largest lymph node was positive in 24% of cases. In addition, neither the first or the second largest lymph nodes were positive in 18% of cases. And if we concentrate the study on the three main nodal stations, 4R, 4L, and 7, the largest lymph node was positive only in 54% of cases. In the other percentage, the smaller lymph nodes were positive. So this is something that we have to keep in mind. On the other hand, non-malignant and malignant lymph nodes have the same size. So it's very difficult to assess just by size if the node is malignant or benign. And there is something else here. This is a simulation study with our own data. Here, in this case, 3 lymph nodes were punctured, the largest lymph nodes in 4R, 4L, and 7, and the sensitivity was 63%. But when another lymph node, another smaller lymph node, was punctured in addition to the largest lymph node in the 3 stations, sensitivity increased more than 20%. So it is important not only to puncture the largest lymph nodes, but also the smaller ones that can be reached by the needle. There is another point to consider here. Are we going to do systematic EBUS or selective EBUS? Selective EBUS means only to puncture the nodes that are positive on PET-CT or large on CT scan. And in this series of more than 100 patients of our own institution, again, there were classified as N2B and N2A. By targeted EBUS TBNA, that means that only the pathologic or looking lymph nodes, large lymph nodes or positive at PET-CT, some of these nodes were classified as the PET-CT, T2B, N2B, N2B, but others were downstaged, and in this case here, none was upstage. However, when the N was N2A, in the targeted EBUS, no lymph node was upstage. However, when it was performed systematically, 14 lymph nodes were upstaged from N2A to N2B or N3. I think this is important to have in mind, and I think that when we put the tube in there, we must make the maximum advantage of the exploration and do it as thoroughly as possible, because it is important not only to stage, but also to assign a more precise prognosis and to decide on the best therapeutic option. So there are 2 issues that need to be thought of here, and one I already mentioned it before. EBUS-EUS is equivalent to video-assisted mediastinoscopy only if in your institution or in your hands, the negative predictive value of EBUS EUS is similar or better than video-assisted mediastinoscopy. If it is lower, then you have to apply video-assisted mediastinoscopy to confirm the negative results of EBUS or to confirm that there is nodal disease. So this depends on every institution. It's not a general rule, but you must know what is the negative predictive value of your explorations. And there is in this situation here, we already know that EBUS EUS have lower, in general, lower negative predictive value than video-assisted mediastinoscopy. And in our institution and in others, and in Turkey, some groups also practice VAMLA, video-assisted mediastinoscopic lymphadenectomy. We think that VAMLA is the best way to stage the mediastinum in this situation. When there is no signs of nodal disease in the mediastinum, but there is suspicion of N1, the tumors are central or larger than 3 centimeters they are adenocarcinomas with a high PET uptake. In this situation, we perform VAMLA, and this is how the mediastinum is left after completion of the operation. We start in the subcarinal space. This is the esophagus, the left main bronchus, the right main bronchus, the pulmonary artery, and we have removed all the fatty tissue and all the lymph nodes of this station. The same here in 4R, superior vena cava, mediastinal pleura, trachea. We have already dissected the subcarinal station, so there is no fatty tissue, no lymph nodes here. And then here on the left side, after identification of the left recurrent laryngeal nerve, we remove the lymph nodes one by one in order not to injure this nerve. So I think that this is the best way to stage the mediastinum when other techniques have a lower negative predictive value. And my colleague, Dr. Sergi Cole, has been in charge of analyzing all our experience with VAMLA. And here are our preliminary results published in 2016 and our updated results published last year. You can see here interesting findings. When by PET-CT the tumor is clinical N0 and the tumor is 3 centimeters or smaller, then the rate of unsuspected N2 is very low. It's about 5% if we combine both results, right? So it could be justified to go directly to surgery without any invasive mediastinal staging. When the tumors are larger, but there is no nodal disease, the rate of unexpected N2 is bigger. It's about 20% if we combine both rates, the initial and the updated. But the striking finding that we didn't expect was this one. When there is suspicion of N1 disease, the rate of unsuspected N2 is very high. It's 40%. 40% in the initial results, 42, almost 43% in the updated results. So I think this is important to have in mind that when there is suspicion of N1, big hilums and so on, I think that it is important to stage the mediastinum invasively because we can find surprises there. And another point to consider is left lung cancers. Clinical guidelines don't make any difference between the right lung and the left lung, but we all know that the mediastinum is not symmetrical. In this situation here, no mediastinal lymph nodes, peripheral tumors, a small sized tumor. If we do not explore the mediastinum before the operation, on the left side, we have this big vascular compound, the aorta and the pulmonary artery, that will prevent us to perform a proper exploration of the mediastinum from the left side, either by VATS or by thoracotomy. We cannot reach the right side, and we know that the left lung cancers, especially those in the lower lobe, cross to the right side through the subcarinal space. So we may find N3 disease from cancers arising in the left lower lobe. This is a very exceptional case, but you may find it. This is an adenocarcinoma of the left upper lobe. It was diagnosed. It has a positive hilum. This is N1 disease in the hilum. No problem with that. And the patient underwent EBUS. You can see every container here contains samples from one lymph node. There are 20 lymph nodes that were punctured here, 20 lymph nodes. EBUS diagnosed N1 disease, but all the mediastinal lymph nodes, right and left, were negative. There is also one container for microbiology here. We always do it. We perform confirmation by VATS, by video-assisted mediastinoscopic lymphadenectomy, VAMLA, and all the lymph nodes were positive. Of course, the amount of cancer was very small, but 4L, 7, 4R, and 2R were positive. So if we had indicated resection only with the results of EBUS, we would have confirmed N1 disease and we would have identified N2 disease, but we would have left N3 disease in the chest. And then the patient would have had a worse prognosis than anticipated because we thought that it was only N2 disease. So this is a very exceptional case. You don't usually find all these negative lymph nodes and then all of them positive at VAMLA, but keep it in mind because it is very important to confirm negative results of EBUS. This is our experience with VAMLA for left lung cancers, 192, and the prevalence of nodal disease was 17%. Most of it was single station, but there was one N3 disease without N2. And when there is multiple station, then we have more N3. So in total, we have 5 N3 disease from left lung cancers. I think it's important to keep this in mind. Staging should be different from with right and left cancers. On the right side, you can always perform a very nice lymphadenectomy of the paratracheal stations with no problem, but you cannot do that from the left side. The M component, some findings are similar to the 8th edition, others are different. For example, the blue line and the red line have the same prognosis. This is blue line intrathoracic metastasis and red line single extrathoracic metastasis. However, in the 8th edition, multiple extrathoracic metastasis in one organ or in several organs had the same prognosis. But in the 9th edition, we have nearly 15,000 patients. In the 8th, we only had 5,000. So here we found that multiple extrathoracic metastasis in a single organ system has different prognosis from multiple extrathoracic metastasis in multiple organ systems. So the 8th edition M1C was subclassified, as I mentioned before, into M1C1 and M1C2. What we could not do with this analysis was to confirm the definition of oligometastasis. We could not validate it. You remember 5 metastases in a maximum of 3 organs, because we found that prognosis is a sort of continuum. There are several cut-offs that separate different prognoses, and I think that we need more cases with more precise identification of the organ location of metastasis. Maybe in the 10th edition, we'll have more data and we'll be able to define oligometastatic disease. For the M, I think we are on the right side if we do a PET imaging of those patients who are candidates for radical resection. And PET is useful for the whole body except the brain, as these recommendations mention here. And we have to do MRI of the brain as a first choice. If we don't have it, then CT scan of the brain to rule out metastatic disease in the brain. So the innovations, again, you already know them. And regarding the stages, there are some changes that are caused by the separation of N2A and N2B. The first thing to have in mind is that T1 N2A has better prognosis than stage 3A of the 8th edition, so it was aligned, put down to the stage 2B instead of 3A. T1 T1N1 has been downstage to stage 2B because prognosis in the 9th edition database was better. And T2N2A has also remained in 3A, but T2N2B has worse prognosis than 3A, and it has been upstaged to stage 3B. On the contrary, T3 N2A has been downstage from the original 3B to the new 3A, and only T3 N2B remains in the 3B stage. And there are no other changes because the changes in the M1C category have no changes in the stages. So the problem here will be how to treat this new tumor that we didn't have in the 8th edition, T1 and 2 and 2A. And the thing is that if we are serious and we try to be as scientific as possible, treatment must derive from properly designed clinical trials. A mere change in classification does not mean a change in therapy. And this is very well explained in these two papers that were written for the 7th edition, but they are good for the 8th and for the 9th, because in the 7th edition, some tumors moved from one stage to the other. And some people thought that the new tumors had to be treated with the treatment of the new stage. And this is not okay. There must be new clinical trials with the new TN2 categories to find out what's the best treatment for these new tumors that are new because the N2 category has been subdivided. Then we can see here that the clinical stages separate very well, also in pathologic staging, and the new stages have been confirmed and validated in different populations, depending on the type of database, depending on histology, on geography, on performance status, on the period of diagnosis, and on the therapeutic modality. In all these populations, the stages that I showed you make sense and are okay. So I think that the newer stages are very solidly based on data, and they have been validated thoroughly. One important thing that we have done for the 9th edition is that we have analyzed separately those patients who underwent induction therapy, neoadjuvant therapy. And here we can compare these 4 graphs. This is the clinical stages of tumors treated surgically only. These are the clinical stages of tumors treated non-surgically. you can see that there are some differences, but not so apparent as in the surgical cases. In the end, the survival graphs tend to get together. Here we have the pathologic stages of complete resections, R0. And you see, this is the graph where the survival curves separate the best. You can see there is no approximation or overlapping. However, when we see the patients who underwent resection after neoadjuvant therapy, the survival graphs tend to get together. So, because many more patients will get induction therapy now with the new targeted therapies and with immunotherapy, I think it will be necessary to have survival graphs with which we can compare our patients. Because if we a YPTNM, we cannot look at this survival graph because this survival graph does not represent the survival of those patients who underwent neoadjuvant therapy. So I think this will be more important for the 10th edition, and we will have to insist and do more detailed analysis of those tumors that have undergone induction therapy. STAS is there. We already know how important it is. And I think it will be very important for thoracic surgeons that the pathologist found a easy way to diagnose STAS intraoperatively, because if there are STAS, we may change the extent of our resection, and we may do a bisegmentectomy or convert a segmentectomy into a lobectomy if there are STAS there. And nowadays, intraoperative assessment is not so precise. So maybe in the future, we will have a better intraoperative diagnosis of STAS to make proper therapeutic decisions. In summary, this big change in the history of the TNM classification, this is the most important change, has implications in the stages because we have created new tumors that we didn't have in the previous editions, and this has meant that some tumors have moved from one stage to the other. In conclusion, in the clinical implications is that we have, with the 9th edition, a more refined prognosis of the anatomic extent of cancer on the condition that we do a precise clinical and pathologic staging, and also because some tumors change from one stage to the other, we have to plan therapy in the most thoughtful way, not simply because a tumor has changed from one stage to the other because of the classification. We have to change treatment. We have to be very thoughtful and very careful in planning therapy for these new tumors that have changed from one stage to the other. And with this, I finish my presentation, and I will be happy to take questions from the audience and from the moderators.
Dear Ramon, and thank you so much for this excellent presentation. We really appreciate your time and all the knowledge you have shared with us. Now we will move on the question and answer session. I've also sent the question in the chat. First question is from Dr. Kahya. Lung cancer staging is based on the analysis patient data uploaded to data capture system from various countries worldwide. How do you assess the quality of this data?
The quality of this data, there is one way. These statisticians have red flags, and they know, for example, if a tumor is classified as T4, but the descriptor is not one of the T4 list, they know that. So this is one check. Also, if If the tumor is classified as N2 and there is no mediastinal lymph nodes removed, for example, is 0 or not recorded, then there is another quality check that we can do. What we cannot do, because with more than 100,000 patients that we receive, we cannot check the original records. We have to trust our collaborators on the data that they send to us. We can do quality checks on the forms that we receive, but we cannot compare those data with the original records of the patients.
Thank you. The other question is Dr. Volkan Erdoğdu. What should be the define of a central tumor? Should it be determined as a distance of 2 centimeters from the hilum or as being within the inner 1/3 of the hemithorax? A perivertebral lesion could also be considered central. It's important to clarify the define of a central tumor. What are you told on this matter?
I think I will clarify nothing because there are so many definitions and ways to measure the distances and so on. I think what we do in our hospital, you don't have to agree with me, but we use a very simple method. Is the outer 1/3, middle 1/3, and inner 1/3. So if the tumor is in the outer 1/3 on the axial CT scan, this is peripheral. If it is in the middle or in the inner 1/3, this is central for us. But as I said, there are several methods that measure the distance of the tumor from the chest wall and the midline of the mediastinum and so on. But I don't think if they are very useful clinically in practice.
Thank you. The other question from mine. How do you think artificial intelligence and advanced imaging technology will shape future TNM staging system?
Yes, during the 9th edition proceedings, we have thought that for the 10th we will need some sort of artificial intelligence because we will have, or we anticipate that we will have more molecular data information. We had nearly 10,000 patients with molecular data. We expect that we'll have more in the 10th. I think that all that data will be unmanageable by normal techniques, mathematical techniques. So we will need some sort of artificial intelligence. And the new statisticians at the University of Padova are aware of that. And they will explore the possibility to use it, especially when we want to create prognostic groups, which is the association of TNM, clinical data, molecular data, and comorbidities, and so on. So the amount of data will be huge, and maybe we will need artificial intelligence.
Thank you. The other question is Dr. Emre Özsaray. Could you clarify if there is a differences in survival rates between patient classified as N2A with involvement of the 7th lymph node versus those with involvement limited to lymph nodes 4, 5, 6?
No, there are no differences now. I think it was in the 7th edition we analyzed independently all the lymph node locations. It is true that the number 7 subcarinal had a tendency to have worse prognosis, but the differences were not statistically significant. And the subaortic lymph nodes had a tendency to have better prognosis, but again, we couldn't prove it because the differences were not significant. I think we need more data and more precise location of the lymph nodes to be have more solid conclusions on that.
Oh, thank you. The other question is Dr. Mehmet Ali Bey. Given a false negative rate of less than 2.5% with cervical mediastinoscopy, would you still recommend the use of WAMLA?
Well, it depends. It depends on how you do the mediastinoscopy. The ESTS agreed that a clinically acceptable mediastinoscopy is the one that has lymph node biopsies from 4R, 4L, and 7. This is the minimum. So if you biopsy one lymph node from each station, you are okay. I mean, you are following the guidelines. But we know that there are many more lymph nodes in the mediastinum, more than 3. And if you leave them there, you will never know. You will never know how they are under the microscope. So when the mediastinum is normal, in our institution, we do VAMLA. We are not happy with just biopsying a few lymph nodes because when the mediastinum is normal, the amount of a tumor by definition has to be very small, and you cannot identify it only by simple biopsies. You have to remove as many lymph nodes as possible so that the pathologist has more lymph nodes to analyze, and the result will be more precise.
Thank you. And maybe a last question. Dr. Gökhan Kocaman, what are the indication for direct surgery in cases of N2A disease according to the NIGHT TNM staging system?
Well, I don't know because there are no clinical trials. So it is true that many think that they operate up from the single station N2, but you have to be sure that it is single station. And I think that the only way to be sure that the tumor is N2A nowadays is by a VAMLA, not even by mediastinoscopy. So, but again, I think that the patient is in the best condition now, and the patient can receive induction therapy with a higher probability to receive the whole therapy. You know, if you rely on adjuvant therapy, some of your patients will not receive the full therapy. So in our institution, we favor induction therapy even for minimal N2 disease, because we think that the patient is in the best conditions at that time to receive the full therapeutic protocol or regime. But others think differently. I know that there is a lot of interest in performing upfront surgery from N2, but I think we need clinical trials to have proper information on that.
Thank you so much, Ramon. We deeply appreciate time you have dedicated to sharing your insight with us. Your expertise and thoughtful perspective have made this session truly valuable for all of us. We look forward to future discussion and collaboration. Until then, take care and see you next time. Thank you.
Sure. Thank you very much for having me. It's a pleasure and an honor. Bye-bye.
Bye bye. Thank you.